So with that, I'm very honored to welcome Dr. Jérôme Bertherat, who is also a leading expert in endocrine rare diseases. As we also know, like a huge contributor to the Carney Complex community. We're very, very grateful that he was willing to join us. And he's going to share more about the National Rare Disease Network that are advancing clinical research. And again, you want to hear from him more than you want to hear from me. So I'll step off and allow you to hear him speak.
Well, thank you very much for the invitation. I'm sorry that I couldn't travel to Phoenix to meet you, to see also my old friend Konstantin Stratakis. Because I had to go to Italy, I accepted the invitation to give a talk and participate in a meeting on adrenal insufficiency here. But I will try remotely to participate. I also wanted to really thanks and congratulate Hélène Bouma. I'm quite impressed that she started a patient advocacy group for Carney Complex, and I can imagine that this is a huge challenge. And organizing this meeting, I think, is clearly a sign of a success. So I will share my screen. You will let me know if there is any problem. You should see my slides now in the presentation mode. If not, let me know. And if there is any problem with the connection, the sounds, or the image, also just let me know, just shout out. So Ellen asked me to talk, of course, about what we are doing on Carney Complex, but also to present how we organize the network, both for clinical care and for research around Carney Complex and other causes of adrenal Cushing. So I will, during the talk, present to you what's at the national level organized for now 20 years as part of the National Plan for Rare Diseases. Then the Network for Rare Endocrine Disease that I chair at the national level, and how this somehow national networking helps for Carney Complex genetic diagnosis, clinical research on Carney Complex, and translational research on Carney Complex. So I, I have to acknowledge first that what I'm going to describe to you apply to a country, France, that has some specific feature. For instance, the population is 67 million, so it's quite large for a European country. But compared to the biggest states in America, for instance, USA or Brazil, this is not that large. We estimate in France that there are 3 million of rare disease patients, accumulating all the sorts of rare disease, of course. And one thing that makes probably the national plan and how we organize that I will show you feasible is the fact that in the country we have one national health insurance that cover everyone. So it's a national system. So patient can travel everywhere because the reimbursement is made by the same insurance. So the National Plan for Rare Disease started a little bit more than 20 years ago, and patient advocacy groups were clearly key to promote and to lobby for this national plan and to have this organization with a specific center for each type of rare disorder. At the start of this plan 20 years ago, 133 reference centers for rare disease, so they're covering all different types of rare disease, were recognized by the Ministry of Health. They had various missions around care, education, research, and production of guidelines. The second layer of this national plan, 3 years later, was to develop along with this national expertise, because you had initially one reference center for all the countries. So for instance, in 2005, we are going to celebrate the 20th anniversary of the rare adrenal, reference center for rare adrenal disease that I chair. Um, Initially, we had only our reference center. So when the patient was living far away from Paris, where I'm working, and where the reference center is localized, he had to travel to our center. So it was decided to develop at the regional level competent center. So for each of the 133 reference center, you will find acknowledged by the physician and then endorsed by the Ministry of Health competence center at the regional level that are usually in university hospital. And the last step of this program, the third layer, started a little bit more than 10 years ago. It was in order to promote communication, interaction, and to have each center using the knowledge of the other one and benefiting from the experience of the other one. Networks that were defined and that cover a group of rare disorders. You will see the name of the networks on the next slide, and you will realize that in fact they are organized mostly around each medical specialty. There are 23 networks that reunite several reference and competence centers in a given field. For instance, here you will have the network for rare heart hereditary disease, another one here for rare liver disease, and here the rare endocrine disease network, the one that I coordinate these last 10 years. And Carney Complex, because of adrenal Cushing, sit in the field of the reference center for rare adrenal disease that is part of the network for rare endocrine diseases. So I'm going now to describe this network and what we are doing in this network. And this is similar to what each network are doing because the mission are defined and supported by the Ministry of Health with the same mission for all the networks. So the good thing also is that because we have the same mission, if one network innovates something that is quite successful, the other network can then start to do the same thing. So there is also somehow networking between the networks. So I will describe now the network for rare endocrine disease. So we have 9 national reference centers. One here, coordinated by a pediatrician for rare disease altering growth. Another one for rare gynecological disorder. Another one for disorder of sex development. Another one for rare pituitary diseases. Another one for anorexia nervosa starting before puberty. At this age, this is a rare and very difficult situation. Another one here for rare lipid disorder. So, of course, we're not talking about common lipid disorder, but the very severe genetic one that starts in infancy. Another one here for rare disease of the thyroid. Another one for rare disease of insulin. So, of course, we are not talking about regular diabetes here, but lipodystrophy or very specific form of diabetes that start in neonates, and the reference center for rare adrenal disease. So these are 9 reference centers that are unique at the national level. And then they are working with all the competence center. Each reference center has its own competence center, of course. And they have associated reference center in limited numbers where there is need either for geographical coverage or for a specific expertise. If I'm just referring to my own center for rare adrenal disease, we added over the time and the successful field of evaluation of this plan 2 other associated reference center for rare adrenal disease. One in Paris is specialized in adrenal cause of hypertension, which means rare cause of primary aldosteronism and pheochromocytoma. And another one, which is located in Bordeaux, in the southwest of France, associated pediatrician, and is giving a specific pediatric expertise and also a geographical coverage. And then we have the competence center. If we just look here on this map at the competence center, the blue dot for the adrenal disorder only, you can see that we have now quite a good coverage at the national level and also overseas, which mean the Réunion Island in the Pacific Ocean, that is a French territory, and in the French Caribs, the Martinique and Guadeloupe. Not very far, in fact, from America, of course, because we don't want the patient from this territory to be isolated from the expertise. And all these blue dots are usually localized in university hospitals. So you can have there the multidisciplinary expertise that you usually find in a university hospital. The network is not only, of course, the association of reference and competence centers, so of somehow clinical department, but we have also on board patient association. And for instance, you have here the logos of most of the patient association of the Firando network. For instance, here, the Adrenal Association. So in France, that's the Adrenal Associations that cover somehow Carney Complex. We don't have a specific patient advocacy group for Carney Complex. Another one here for acromegaly. So somehow Carney could also be interested in this patient advocacy group, but most of the Carney patients that I know are a member of the Adrenal Association. Apart from patient association, we have research laboratory, 22, that are highly specialized in various types of rare endocrine disease. So they are doing translational and basic research in INSERM and CNRS units, so the equivalent somehow of the NIH in the States. We have laboratory diagnostics, so that's the clinical laboratory. We have genetic laboratory, that's common, I would say, to all the network, and we have, which is specific to the Firando network, hormonal biology laboratory. We have, as partner and not exactly member of the network, scientific society, for instance, the French Endocrine Society or the French Pediatric Endocrine Society are closely collaborating with Firando. And we have also actor of social worker with different layers of organization at the national level, most of them being state employee. And they are organized in region, and we interact with them in order to solve the social issue of our patients. The Firando network organized this working force around working groups. So I apologize because this slide, you have the names of the working groups in French, but I will translate some of them. For instance, we have one here dedicated to drugs. And we have one issue right now in the country and all over Europe that we have more and more drug shortage issue. So we need to solve that. And this is one of the tasks of this working group. This working group is also identifying drugs that we use off-label in order to promote recognition by the health authority of the use of this drug for our rare endocrine diseases. One group here is dedicated to how to support patient association. One group is dedicated to research, trying to promote research in the field of rare endocrine diseases. And one group here is dedicated to guideline, and I will come back to that later on. One of the main missions of the network is to disseminate information so that patient, general practitioner, any type of healthcare professional that are not aware of this disease could find some information about the disease, but also where to refer the patient. That's also one of the most important tasks of the networks, to disseminate in easy to find way the information on where is the expertise and where to send the patient, or where, if you are a clinician specialized but not highly specialized, where to send a sample for a specific biochemical analysis. And one of the tasks is also to deliver educational material in a very simple form for medical students, nurses in training. So short video that explain various types of rare disease. So for instance, one on Cushing syndrome, and we are now right now producing one on Carney Complex. One task of the network is also to promote information and try to stimulate, apart from the physicians that are in the center, nurses and researchers in the field of rare endocrine disease. So we organized annual meeting dedicated for nurses. You have here the poster of the 2003 edition. Of the Nurse Day around rare endocrine disease, and on the right, the poster of the same year edition of a meeting targeting researchers trying to promote research in the field of rare endocrine diseases. Here is the guideline. So when I say guideline, it's not exactly how we call it in France. We call it National Protocol for Diagnosis and Treatment. They are produced at the request of the health authority. They are part of the mission of the reference center, and they are posted on the website of the National Agency for Health, Haute Autorité de Santé, which means that because they are produced with the methodology that is defined by the national agency, and because there are multiple stakeholders in this guideline, they are used also for recognition of what type of treatment or care should be reimbursed as part of the national health insurance. So what's written in this guideline would be accepted by the health insurance. And they are all following the same format that is defined by the national agency. There is a first very short description, not more than 3 pages for the general practitioner. Then there is a first part dedicated to how to diagnose the disease, then how to treat the disease, and then to identify specific situation, like for instance, what to do during pregnancy, or a specific situation depending on each disorder. You might have some specific situation, or depending also on the age of the patient, and long-term follow-up. So you have here the list of several guidelines that have been already produced for rare endocrine disease. For instance, the Cushing syndrome guideline, the first edition was produced in 2008 and it was revised in 2023. And for Carney Complex, we produced the first one 2 years ago. And before producing it, we needed to have some clinical research to get data to define how to manage this patient. And you will see later on how we collected this data from clinical research. So I just show you the example of the guideline about Carney Complex. It's, of course, completely free to download on the website of this National Health Agency. So it's in French, but I'm sure you can find many tools on the internet to translate it. And we are currently working with the journal of the French Endocrine Society to have it, the main message published in English, so it would be accessible worldwide in English. So there is the first part dedicated to the GP. Then you have the main corpus of the guideline, and then that's right for all the guidelines. We have the list of all the articles with the main finding and the main summary of each article that were used to produce the recommendation. So you have here the summary of the Carney guidelines. First step is the diagnosis. We list first which type of professional should be involved in the diagnosis. For instance, there is the endocrinologist, but also the cardiologist, also the biologist, the radiologist, and so on. Then, what are the clinical signs and how to proceed for diagnosis? The endocrine manifestation, the non-endocrine manifestation, the genetic diagnosis, and then treatment. And we define here again which type of professional should be involved. So there is not only the physician, but also nurses, psychologists, physiotherapists, and so on. And then we describe the various type of therapeutic options that are recommended. And then, and that's systematic in all type of guideline, a specific chapter on patient education and what is the impact on everyday life. And if there is specific impact for people who are working, this should be also described. A specific chapter is dedicated to patient association so that the physician can refer the patient to the appropriate patient association. And then long-term follow-up. Then you have the list of all the centers that can take care of the patient. And there is something I think quite unique and useful. There is an annex where we list for each age, starting from birth, what type of clinical examination and imaging or biological investigation should be done. And what's listed here, of course, is accepted by the health insurance because that's part of this guideline. And as you can see, from birth to 1 month, 1 to 6 months, 6 months to 5 years, after 5 years, 6 years to the puberty, and then puberty to adults, and that adults with a specific emphasis on transition, which is a major mission that the reference center have. Most, if not all, the reference center have on board both pediatrician and adult physician, and the transition period is something that we should proactively work on within this reference center. Apart from the guideline, the request from the health authority is that we organize multidisciplinary discussion. So of course, there are already multidisciplinary discussion in each reference center, so somehow and competence center, so somehow at the regional level. But for very specific and difficult situation, each reference center has the mission to organize also a national web-based multidisciplinary discussion. So you have here the list of the such national multidisciplinary web-based discussion meeting, and one here is dedicated to adrenal. So what we are going to discuss here are all type of adrenal disorder, and Carney Complex, because of the adrenal manifestation, is also discussed in this multidisciplinary discussion. When there is a very difficult situation for diagnosis that has not been solved at the regional level, so it's highly selected cases, or of course a difficult therapeutic discussion, and also when there is no genetic cause identified and we want to move toward what we call the national genomic plan that I will present to you just on the next slide. And to have the patient and his family investigated in this national genomic plan, it has to be first accepted in this multidisciplinary discussion at the national level. The mission of the reference center is also to develop educational program for patients and also now for their relatives. And you have here a list of various programs that have been developed by the reference center. In the field of adrenal, of course, the big topic is how to prevent acute adrenal crisis. And you have here an example with all the educational material that have been developed for that as part of the mission of the reference center. But there are also educational programs for congenital adrenal hyperplasia, for instance, if we just stay in the field of adrenal disorder. And once the program is developed by the reference center, we made all the effort to train the competence center to develop this program at the regional level and to have them using the educational material that have been developed. As part of the national plan, emergency cards have been developed also. As you probably all know, it's always very difficult when a patient with a rare disease came in the emergency room because usually the physician that is present at that time does not know the disease and that does not know how to react in this situation. And sometimes it's even worse than that. The physician doesn't really hear what the patient is explaining about his own disease. So the idea was to develop in a similar format, and I just show you here the example of the one for endocrine disease that have been developed by the Firando network. Some key explanation that the patient could show to the emergency physician. It was the idea that because it's a national system and that the card have the same appearance, on the long term, the physician would know how to react when they see this card, and this would help and speed up the appropriate management of these patients. The national plan has developed also a national database. So each time a patient comes in a reference or a competence center for a consultation or an hospitalization, we need to put the main data in this national database. And because now the funding of the reference center is based along with many different parameters, but it's one of the criteria is the number of new patients each year and the overall number of patients managed each year. You can imagine that, of course, the data are quite well entered in a quite exhaustive way. So that's helpful not only, of course, to see if there is an appropriate dissemination of the resources in the territories to manage these patients according to the number of patients, but also to identify patients for research, clinical research and translational research. So we move now to research, and somehow genetic diagnosis is close to research, even though it's not anymore research. When we started genetic diagnosis for Carney in our center, that was because of our long-term collaboration with Constantine. So very soon after he identified the gene in 2000, we started to genotype in my lab in Cochin Institute patients. So that was part of research. So that was, of course, very important to progress in this field. But when you do a genetic diagnosis in a research lab, it takes time, and it's not anymore usable for clinical management because you need to have some standard, and research labs are not appropriate for that. Even if they do a very good quality job, they are not accredited for that. So since 2005 now, genetic diagnosis for Carney is done in the genetic laboratory of Cochin Hospital. So it's just the next building to the research lab. So it's very easy to go back and forth and to interact, which is very important both for clinical diagnosis, the genetic diagnosis of the clinical laboratory, but also for research. And because of the rarity of Carney and the history of research in the field of adrenal tumor in our hospital, all genetic diagnosis for Carney is done in France in a Cochin hospital. So there is a single center for genetic diagnosis. So we have quite an exhaustive view on all the genetic analysis at the national level. And we have also referral from various European countries. So historically, it was sequenced by Sanger and gene deletion by MLPA. And since 2019, so that's now 6 years, it's done on a gene panel that include RNA and C alpha that Constantine talked about just before and that you probably all know, but also all type of other genes of adrenal tumor and endocrine tumor in general. So it's really a multi-panel sequencing gene. So that's quite powerful in terms of identifying in Carney Complex patient and patient with isolated PPND genetic alteration, but it's also not always positive. I mean, we don't always find a mutation. So since 2021, we have now this national genomic plan, France Medicine Genomic 2025. It started in 2021, and the aim was to have the plan completely developed in 2025, which is what happened. And the idea of this national plan is not to do genomic for research, even though the data can be used in a second way for research, but for clinical care. And it's supported in part by the health insurance. So there are a list of rare endocrine diseases that have been accepted for this national program. And for Carney, that's primary pigmented nodular necrotic disease. So the adrenal cause of Cushing that you see in Carney that have been selected, as well as another cause of bilateral adrenal tumor that is called bilateral macronodular hyperplasia. That is a different disease, but also a genetic disease, even though it's a disease that we usually diagnose in adults between 50 and 60. So we need first to do the gene panel, and if the gene panel is negative, then we discuss the case in this national multidisciplinary discussion, and if it's accepted, it's sent to the platform. And I would say that we have been quite lucky to have access to that for PPNED, because since we are doing that for PPNED and patient with Carney, because we can also use that for Carney when there is no PPNED, we increase clearly the yield of positive genetic diagnosis. So now, and I will discuss that in the later talk on endocrine manifestation of Carney that is already recorded. When we have PPNED and other manifestation of Carney, we have, I would say, 85% of the sample that are now positive. We find an alteration that explain the disease. And when we have an isolated PPNED, we have on the top of that duplication of C alpha that can be identified on the panel, but that are confirmed with the genomic analysis, and also the border of the duplication to be sure that this is C alpha and not another gene that is implicated can be confirmed. And it's clear that for PPNED and Carney, with this approach, we had a huge benefit. And for macronodular hyperplasia, for instance, the added value so far is not that high, even though we can identify with this genomic approach some alteration that have not been identified by the panel. But for Carney, clearly, this was very helpful. So our view now is that the pending proper selection of the patient or clinical data, the percentage of negative case is probably not more than 15%, which is not something I would have said 5 or even more 10 years ago. So, as you all know, the benefit for the genetic diagnosis when you find an alteration that explains the disease is to guide patient management. It's, of course, especially important for patients with a single manifestation, like, for instance, PPNED, if you find an RNA mutation, or patients with minor manifestation of Carney, because you know that there are many manifestations of Carney, some are more specific than others. Of course, familial screening for early diagnostic and early treatment. Constantine just mentioned before that now patients that died from Cushing are not seen anymore. Overall, the prognosis of Carney patients this last 20 years, so since the start of familial screening and prospective follow-up of the patients clearly improved because we can treat the patient when the manifestation is at a very early stage before major complication. And this genetic approach combining A1A C-alpha duplication can also guide patient monitoring with the fact that we have, but this might be a specificity in France, some mutation, and I will discuss that in the next talk, that are associated mainly with PPND and no other manifestation or very few other manifestation of Carney, and for instance, no cardiac myxoma. So in terms of explanation for the patient and follow-up, that's important to know. And of course, also genetic counseling. So I will just illustrate that with two cases. One here, that's a female patient that I'll follow that presented at the age of 40 a stroke that was explained by a cardiac myxoma. At that time, no one thought about Carney, and later on she developed breast cancer, and later on a schwannoma. And at that time, the neurologist thought, well, she had myxoma, I diagnosed a schwannoma, I see that she has lentiginosis. And she was referred to us, and indeed she had Carney with a mutation of R1A. So we did familial screening, and one of her three kids carried the mutation, and at that time she was 24 years old, and she had, as a single manifestation at that time, a skin myxoma and an abnormal 1 milligram dexamethasone suppression, but no bona fide Cushing. And still today, she doesn't really develop Cushing. And then she had three daughters. The three carried a mutation. And one of the three developed a myxoma at the age of 4. And so sorry. Yeah, here is in blue at the age of 4. The grandmother, so the index case, developed a myxoma at the age of 62, and the daughter of the index case at the age of 31. Why I'm explaining this story? That's because this grandmother here, she had this stroke, and unfortunately, she has this hemiplegia as a sequela. But the daughter and the granddaughter, because the myxoma was diagnosed by routine screening, because they have annual cardiac ultrasound and sometimes also MRI, the myxoma was diagnosed before any complication. So for them, the story is completely different than from the grandmother. And the grandmother, when she was diagnosed with the recurrence of another myxoma, she was quite terrified because she had a very bad memory of the first episode. But after the surgery, she told me, well, in fact, that was fine. And I realized that by monitoring, this changed completely how things are going to go, because it's completely different when you do a cardiac surgery as an emergency after a stroke, and when you do it planned. We do that quickly, but it can be planned, and the outcome is much better. And of course, there is no complication. Another story here, the index case is 5 years. She has skin myxoma, and that's when I realized that by explaining with all the reference center and the competence center, when we touch the other specialists, the dermatologist, the cardiologist, what Carney is this last 15 years, there is an improvement, because the dermatologist thought about the possibility of Carney when he saw this 5-year-old girl with a single skin myxoma and lentiginosis. So she was the index case of this family. Later on, she developed Cushing, had bilateral adenectomy. The mother was the mutation carrier, and at the age of 39, when the diagnosis was made, she had just lentiginosis, and the grandmother had the mutation. The grandmother had a full workup, and she was fine except skin myxoid lesions that were operated earlier, and we couldn't get the sample to verify, but this was probably, of course, skin myxoma. But unfortunately, she did not came back for follow-up. She denied any follow-up. And at the age of 62, she had a stroke. And in fact, this was the consequences of a cardiac myxoma that was not diagnosed just because she didn't come back for follow-up. So the message here is the benefit of familial screening is that once the mutation is identified, the patient need to come back at least 1 year for follow-up. And this is clear that apart from C-alpha duplication and the rare mutation that we have in France that do not predispose to cardiac myxoma, all the other A1 mutation, you need to do at least once a year, if not in some specific situation, more often a cardiac ultrasound for that. Let's talk now about clinical research on Carney Complex that we have developed in this framework. So as part of the national plan, there was a specific budget for clinical research for rare disorder. And we applied for Carney because when we were asked to produce a guideline, we say, well, but there is no clear evidence. Everything in the literature included large series that Constantine and Dr. Carney did, and we collaborate with that, and we are very proud of this large series, but they were retrospective studies, and there is no prospective studies. So if we want to give recommendation, we need to get, at least at the national level, some prospective data. So what we've done here is to offer the possibility to all the competent and reference center that have Carney complex patient to include them in this prospective monitoring for 3 years, where each year a series of imaging and biological assays, as well as clinical examination, including a dermatological examination by a specialist, would be done for 3 years. So as you can see, 70 patients were enrolled. At the end, that's 62 patients that were still followed, which is quite good. Of course, there are some follow-up and one patient, unfortunately, who died, but this is quite acceptable. So we use that data to determine the age at diagnosis, as you can see, of the manifestations. Some, as you already know, can be diagnosed very early in children, like Cushing or cardiac myxoma. Other, like acromegaly or thyroid tumor, are diagnosed later on. And you have here, and I'm not going to spend too much time on this slide, the percentage of the various manifestations before the inclusion. So that was, in fact, the manifestation that led to the diagnosis of Carney. Then the first screening, and then screening each year. So there is a slight increase of some of the manifestation, but with all this data and, of course, all the pre-existing literature, we thought that we had enough evidence to release the guideline. And one key message from that was, as Constantine already mentioned, the fact that cardiac myxoma can recur. I say sometimes that a patient that already had a cardiac myxoma has probably more chance to have a second one than a patient who never had a cardiac myxoma. And we know that there are some A1A mutations that are more prone to develop cardiac myxoma, even though there is no clear genotype-phenotype correlation. And when we look at the time between each myxoma for each patient, some of them had to wait years before to get a second or sometimes a third myxoma. But other, as you can see here, developed a second or even a third myxoma in less than 3 years. It's not the same one that recurs. It's another myxoma. Sometimes it's even in another cardiac chamber. So it's really put the emphasis that monitoring of cardiac myxoma is something very important in these patients. One thing that we observed, and this comes back somehow to the presentation of Constantine, is that we did, as part of this program, systematic spine MRI in this patient at first investigation. The idea was to look for schwannoma. And in fact, we found several patients with nodules in the vertebra here that, according to the imaging characteristic, are mimicking what we know in osteochondromyxoma, which is a rare tumor that Dr. Carney described in Carney Complex. It turned that some of our patients were operated from osteomyxoma in other locations than the spine, and we could compare with our bone radiologist this imaging. And that's almost half of the patient that presented with this lesion that has osteochondromyxoma, and follow-up tell us that and I have for some of them 20-year now follow-up, they don't change. They seem quite stable over time. And I think it's quite important to know that because it's quite often that when these lesions are found, there is the fear of malignant disease and of metastasis. And if we can, with a radiologist that is really a bone expert and that know Carney, classify them as osteochondromyxoma, they never have a positive FDG PET scan, for instance. That's quite reassuring, and you can just offer monitoring. That's the genotype-phenotype correlation with PPNID. I don't show this slide too much because it will be presented during the next talk. And as well as what we are doing after this prospective follow-up, following specific manifestation like gonadal alteration in male and breast tumors in female. And that's where we came to the conclusion that there is a slight increase frequency of brain cancer in Carney Complex women. That will be discussed in the next talk. And I will finish about what we are doing in terms of translational research on Carney Complex in this network spirit that we have in the country and I would say in Europe. So what we are doing on Carney is mostly, and we are talking now about translational research in the field of adrenal tumor. And we have here two networks that are academic networks, so they are not defined by the health authority. They are just like a scientific society, endocrinologists and researchers that just met and decided to networking and to develop a network. We have a national network that started 30 years ago, the COMET network dedicated to the adrenal tumor. And we have the European network that is similar to the COMET network, but at the European level, ENSAC, the European Network for the Study of Adrenal Tumor, that started now a little bit more than 15 years ago. This network, they can apply to funding for translational research on Carney, and some of this funding, sometimes we are lucky to have a specific section for rare disease, which is not always the case, but that's very important. And of course, specifically in the field of Carney. So we have in France the National Research Agency that gives this funding, and we were lucky to have funding for at several occasions for Carney. The idea of this funding is that you need to do that in network. You need to have at least two, and the optimum number is 3 or 4 teams at the national level that will work on the project. And for some of the call, you can have non-European teams. And for instance, we had the opportunity to have Konstantin Stratakis on board on 2 of these applications. And another one where we could also collaborate with the Sao Paulo State, with the Brazilian team. And that's the national support. At the European level, there are also various support, and here you need to have several countries on board to be supported. I give here some example of what have been produced. That's on bilateral adrenal tumor, but they are not Carney manifestation. But that's interesting because it illustrates how, if you want to progress in a specific field, it's good to do that in parallel with similar diseases. And for instance, and Konstantin already mentioned this paper, we identified in the NSAT network, and Felix Böllstein from Germany was a key player for that, mutation of the catalytic subunit of PKA, donc the C-alpha subunit, in patients with adrenal adenoma, so a single tumor, and the mutation is only present within the adenoma. It's not a germline mutation, it's not a familial disorder. But then we were discussing this data with Konstantin because we are clearly in a spirit of collaboration and we exchange our results even when they are not published. And we realized that Konstantin, I find on the same gene duplication in patients with bilateral adrenocortical hyperplasia and adrenal Cushing. And this is what we know as a cause of PPNED, duplication of C-alpha. And these two alterations were reported in this New England paper now more than 10 years ago. Another example where we do a genomic study, so we study all type of genomic aspect, transcriptome, methylome, chromosomal alteration, myrinome, of adenal tumor. And we include in these studies PPNED, along with adenoma with various secretory profile and macronodular hyperplasia. And the comparison of the PPNED data in yellow here with the other tumor type allow to derive hypotheses on the mechanisms of the pathophysiology of PPNED. Then this network and this ANR funding were very useful to develop studies on primary culture of adenocortical cells from patients treated by adrenalectomy for PPNED. As you can see with Hervé Lefebvre from Rouen, we were able to identify alteration of cortisol secretion in vitro. So this, of course, helped to understand the pathophysiology, but this could also give insight for new treatment to control cortisol. And Antoine Martinez, so that's another team in Clermont-Ferrand that was supported by this funding, developed several mice models for Carney where he inactivates A1A in a specific tissue. For instance, in the adrenal cortex, in the gonads, or in the skin progenitor. And he recapitulates some manifestation of Carney. So that's helpful here again to understand the pathophysiology, but this could be also models to test new treatment. And I will finish now to the development of in vitro model for Carney. And here it's a different team, but also supported by ANR. That's Grégoire Van de Castel. So he's working on the cardiac muscles and heart. So he's not an endocrinologist at all. And but he was very interested by PKA and Carney Complex to understand what's going on in the heart of these patients and to understand also the role of PKA in physiology in the cardiomyocyte. And so we developed studies in vitro to understand how mutation alters PKA signaling. And now, and this is ongoing, we are isolating progenitor cells from circulating cells from Carney complex patients with specific mutation in order to differentiate these cells in cardiomyocyte and adrenal cells to develop cell models, not only for pathophysiology, but also to test new treatment that could be useful on the long term on Carney. So it's an approach that, along with what Constantine just described, I think on the long term would be very helpful. So I will stop there. You will see on this slide our collaborators. So in Cochin Institute, in Cochin Hospital, at the national level in the COMET network, at the European network in the NSAT network, and in America, so South America and North America. So of course, the team of Constantine Stratakis, now that it is back also in Europe. Thank you for your attention.